Hello, welcome to Neobiotech International Virtual Seminar. Thank you for attending this webinar, and my name is Gabriel Lee. I'm gonna be the host for today's webinar. We already had 3 webinars during this month. These previous webinars are available to watch in Neobiotech YouTube channel. Today's webinar will be the last one for the July. In August, we're gonna have webinars for every Wednesday as well, but in some area, it might be a late night on Tuesday. Please visit our website or contact your local sales office for registration. All right, for today's webinar, Dr. Murad from Jordan will speak about predictable ridge augmentation and preservation, decision-making, and techniques. During about 1 hour, he will kindly share his experience and knowledge. Please use chat button to communicate with me about any issues other than topic. We'll have a Q&A session after lecture, so please submit your question through Q&A button. Speaker may not answer for all questions because we have limited time to take all questions. If you have more questions or anything for discussion, you can contact Neobiotech website or Facebook page. So from now on, let's have Dr. Murad to start. Please welcome Dr. Murad. Hello, doctor. Are you there?
Hello, Gabriel. How are you?
Hello, doctor.
How's everybody?
Hello, doctor. How are you?
All right. Good, good. How are you doing?
Okay, I'm very fine. Thank you for asking. Okay, let me finish my share screen.
All right, perfect. All right. Can you see my screen?
Yeah, I'm seeing very well. It's
All
good.
right. Are we good to go?
Yeah, please. Thank you.
All right. So good evening, everybody. Good morning if anybody is living in a time zone where it's still in the morning. Let me introduce myself quickly. My name is Murad Shaqman. I'm from Amman, Jordan. The time now is 1 p.m. Let me give you just a brief idea about myself. I am a periodontist. I graduated from the University of Jordan in the year 2000, and then in 2006, I started my periodontology residency at the University of Connecticut in the United States. And after 3 years, I got my master's degree in dental sciences and my certificate of periodontology. I practiced for 1.5 years in the United States, and then I went back to Amman, Jordan to become an assistant professor of periodontology at the University of Jordan in Amman. And since then, I've been practicing there, teaching and practicing, and my main interests are in dental implantology, ridge augmentation, and periodontal soft tissue surgeries. Let me just give you a brief introduction of where I come from. Amman, Jordan. It's in the Middle East, hot zone for a good number of years now. But you might have heard of Petra, which is probably the most famous landmark in Amman, in Jordan. But Trust me, hopefully when this COVID-19 situation is behind us, I hope you all can make the trip to Amman and Jordan and enjoy the many, many beautiful places and many exciting activities to do. Um, I graduated from the University of Connecticut and now practicing at the University of Jordan in the University of Jordan Hospital. And luckily, this is something I have a lot of passion for. Been involved in a lot of continuing education for colleagues and dentists in the fields of periodontology and implantology. And that gives me a lot of drive and passion. And I'm here today not to just like Gabriel said, I'm just going to share with you my experience, what we've been doing and what I find to work in most of the cases. And hopefully we can have a good discussion afterwards. So without further delay, let's get into the topic. A lot of times on social media, I get these, messages about engineering blunders, funny things. You look at those photos and you say, gee, what were they thinking when they designed or when they executed this? And why go far? We actually run into this in our daily practice. This is an example of, excuse me, just a second. Let me just. Just a second, I apologize. All right. So a lot of times in implant dentistry, unfortunately, you come across cases where, this is exactly similar to the pictures you've just seen, just an engineering blunder and basically poor planning, poor execution of implant dentistry in an era we are focusing on prosthetically driven implant placement. So these days supposed to be behind us now, and we're not supposed to be faced by situations like this. You're supposed to be able to predict and appreciate what kind of outcome you're gonna have. So of course, all of us that practice surgical placement of dental implants, the surgical aspect of implant dentistry, this is what I hope for. This is what I wish I can find in every patient. Single or multiple missing teeth, but with plenty of alveolar ridge where you have no issues placing your implants. And, it's a straightforward procedure. Patient is happy, you're comfortable, no stress. Unfortunately, the reality is that in a lot of cases, we're faced by situations where you have significant hard tissue as well as soft tissue deficiencies in those edentulous areas. And now you have to consider, of course, ridge augmentation either at the same time of implant placement or ahead of the implant procedure. And those defects, they come in a wide variety of situations. So you have multiple adjacent missing teeth, you have the single missing tooth, you have sites with vertical defects, with horizontal defects. So it's just a wide range of situations and scenarios that you might be dealing with. The reality is, if you want to practice prosthetically driven implant placement, more than 50% of implant cases, they will require some sort of bone or soft tissue augmentation. And this is a very important thing. You need to look back at, just kind of do an audit of what you've been doing in your office, and think about how many cases are requiring bone grafting or soft tissue grafting. And more than 50% of the cases require some sort of augmentation, which means that in this day and time, clinician practicing implant dentistry has to be proficient in ridge augmentation techniques, has to be capable in diagnosing as well as treatment planning, and of course executing those ridge augmentation procedures to be able to deliver the kind of results that we are aiming for in today's implant dentistry. There was a time when we opened the flap, we looked for the bone and we placed the implants where the bone is. Of course, we don't do that anymore. You need to kind of prosthetically based treatment planning, or prosthetically driven treatment planning. You decide where the crown of the or the restoration needs to be, and based on that you decide where the implant needs to be and whether you have enough bone in that side or you have a deficiency that needs to be augmented. So ridge augmentation techniques are great many. There's so many techniques. Probably the more commonly known techniques, more commonly used techniques are the GBR technique, the guided bone regeneration. The block grafting is a kind of more traditional classic technique. And we got the crest splitting, but we also have other techniques such as the bone ring. We have the distraction osteogenesis for more complicated cases. We have the allogenic blocks. We have the thin bone blocks or split bone blocks. So we have a lot of techniques, and we have a lot of biomaterials for those techniques. Add to that confusion about what technique should I be using, the different scenarios that we talked about. So you have a single tooth, you have multiple missing teeth, you have a horizontal defects, you have vertical defects, you have the mandible, you have the maxilla, you have defects that are within the envelope of the bone, and you have defects that are outside the envelope of the bone. So what we need to do first is to kind of assess the defect and determine what kind of defect we are dealing with. So the very simple or simplified, let's say, approach is determining in what area of the ridge is your defect. So first, if you see on the left-hand side of the screen, you can see the numbers 1, 2, 3, and 4. And 1 and 2 are on the buccal, 3 and 4 on the lingual. So basically, you have, let's say, a series or sequential severity, let's say, of the bone defect. So you have a bone defect in area 1, and then a more advanced defect in area 1 and 2, and so on, until you get to a situation where you have a very deficient ridge, where you have a complete resorption of the alveolar ridge. So that's the first parameter that we need to assess. And I want you guys to kind of remember this as we're going to keep coming back to it. So determine where exactly is the deficiency that I have in relation to the position of the implant. And then the second thing we need to evaluate is whether we are dealing with a single tooth or a distal extension or a fully edentulous cases. For the purposes of today's lecture, I'll only talk about the single tooth and the distal extension edentulous spaces. I'm not going to talk about the fully edentulous because this is a completely different topic. So today we're going to talk about the single tooth situation, and you have the different scenarios that you can have where you have deficiency in area number 1 or number 2 or 3 or 4. And we're going to talk about the extended edentulous spaces or the distal extension saddle, where you also have either deficiency in the area number 1, number 2, or 3 or 4. So we're going to keep coming back to this table. And this is a very nice table from a very nice volume from the ITI treatment guide that I suggest all of you to take a look at when you have the time. So I'm going to demonstrate how we assess those cases and then how we decide what the treatment plan is, and I'm going to show you how we execute those different treatments using different cases. Okay, so the first case, this is a patient I treated during my residency in the US. One of the first cases I treated, she's a 64-year-old Caucasian female, and her chief complaint, as usual, patients, their interest is in replacing missing teeth, not in placing implants. They actually want teeth to chew on. So that's her chief complaint. Her medical history is non-contributory, and she's a non-smoker. Very important aspect. Always need to consider the patient's medical history and the fact whether a patient is a smoker or not. It means that you are supposed to have a different discussion with the patient, emphasizing the risks and complication that we usually observe at a greater percentage in smokers. She has a history of treated chronic periodontitis or periodontitis according to the most recent classification. She suffered from tooth loss, and her plaque control is good. So if you look at her intraoral clinical photos, you can appreciate the edentulous areas on the maxilla as well as in the mandible. The treatment plan initially is to restore to a first molar dentition. And of course, she's interested in getting fixed restorations. So that ideally, we need to place implants in these positions in the number 1-4, number 1-6, number 2-5, and number 2-6 in the maxilla. And for the sake of our lecture today, I'll be talking about how we place the implants on the upper right side of the maxilla. And then we'll come back to the edentulous area on the lower left mandible. So if you look at the panoramic X-ray, that's what we did for a good period of time. We took panoramic X-rays with those calibration spheres. But of course, you need to get the 3D X-ray. And like I said, we're gonna focus on number 1-4 and number 1-6 position. So in the number 1-4 position, if we place an implant, you can appreciate that the apex of the implant, although at the crest we seem to have adequate bone width, at the crest of at the apex of the implant, we would have a fenestration. This is, of course, assuming that we place the implant in the prosthetically proper position. Although crestally I don't have an issue, but there's going to be a fenestration in the apical part. In the number 1-4 position, because of this deficiency that I have mostly in the apical area, what options do I have? Do I go with a guided bone regeneration technique? Do I go with a block graft? Or do I go with a split crest? Now let's go back and look at that classification that we talked about. The deficiency I have is more like a small dehiscence defect. So it's more like a class 1 defect. And this is in an extended edentulous space, okay? So I can either do a staged GBR, or we can do GBR simultaneously with implant placement. And that's probably what I would have done if this was the only step that needs to be, or the only treatment that needs to be done. But in the case of this patient, because she's also has pneumatization of the maxillary sinus, and we are planning to do a lateral window sinus floor elevation, we decided to go with a staged GBR. So we do the bone grafting in the number 1-4 position, and we do the sinus lift. We let it heal, and then we come back and place the implant. So we went with a staged GBR approach instead of simultaneously placing the implants. Because typically, like I said, if this was the only implant that I need to place, and there's going to be a small fenestration of the apex of the implant, I would just do it simultaneously. So I would place the implant and do the GBR at the same time. So that's what we did. We decided to go with a guided bone regeneration. Guided bone regeneration, of course, you can use a resorbable membrane and a non-resorbable membrane. What we did, we used a resorbable membrane. Like I said, this is kind of a more contained defect. The ridge width is more than 3 or 4 millimeters. It's only deficient at cross a small part of the ridge. So it's a small fenestration that we expect. And usually the resorbable membranes, they usually pose the least risk of complications. So that's the plan. We do a sinus lift on number 1/6 position, and we do the guided bone regeneration on number 4. So based on our assessment, based on the classification and the table I just showed you, now we can have like an idea of what works in this case. But it's very important to remember, it's not enough to have a plan. You have to be able to execute. And I want you to look at this gentleman here. He has a plan. He needs to cross from one side to another. But the plan failed because maybe if he had tried that 10 years ago or 15 years ago, more athletic, more fit, he might have been able to pull this off, just kind of swing and jump to the other side, but it failed. So you need to have a plan, but also before you execute, you need to make sure that you're capable of executing that plan. I'm gonna show you what we did in this case and maybe spend a bit more time on what I focus on when I do guided bone regeneration. This is probably one of the more common techniques that we do in implant dentistry today, and a lot of you have used it. Just some pointers, I think, in my opinion, are important for more predictable results. So first of all, like any procedure, incision design is very, very important. This is the area that needs to be augmented. So when I'm designing my incision, I keep this in mind. This is where my graft needs to be. And I want to make sure that I want to keep my incisions, especially my vertical incision, but also my crestal incision, kind of away from the augmentation area. I don't want my releasing incisions to be too close to my augmentation area. So although a lot of colleagues would place their incisions in this area and avoid extending to the mesial of the canine in this case, my preference always is to go with a releasing incision further away. I know everybody is about kind of minimal surgery, minimal invasive surgery, but I think there are certain principles that you need to keep in mind. You want to keep your incisions slightly or further away from your augmentation area. You don't want your membrane, you don't want your bone graft to be very close or sometimes under the releasing incision you're placing. So we place our incision. You see where the vertical release is. Clean incisions, no tearing of the flap, clean, full thickness reflection. We did an osteotomy using a piezoelectric device. Back then, that's what I did. I don't do that anymore. I do a round window. Honestly, we don't do this rectangular window anymore, or we use the very nice kit that we have from Neobiotech for lateral and the crestal sinus floor elevation, where you open the window using just the implant handpiece very quickly, very safely. But that's what we did back then. We elevated the sinus membrane, as you see. What I do a lot of times is we mix autogenous and bovine bone. I prefer to use a mixture of about 50 to 50. Autogenous bone gives you all the kind of inductive potential, induction potential. And the slow resorbing graft material ensures that you have retention of that graft volume, so you don't lose volume. And we go usually to the ramus area to harvest. Now, sometimes you might think, well, I mean, this is a lot of work. Maybe we don't have to use autogenous. Maybe we can just shave a little bit from any nearby, prominent. And sometimes you can do that. But if you need a quick and fast way to harvest autogenous bone chips, after a lot of attempts with a lot of devices, in my opinion, this is the safest, fastest, least invasive approach to harvest autogenous bone chips. If you're a guy like me that likes to use autogenous bone chips in his grafts, this is what you need to be using. This is the ACM the auto chip maker from Neobiotech, and I love this thing because it's fast, it's quick, it's clean, and it's safe. This is the most important thing. So you got this drill and you got the sleeve on it, and that keeps the bone chips inside within the confines of the drill. And it's very quick, very safe. You see a very small hole and you harvest a lot of autogenous bone chips in very quick time. So we harvest our autogenous bone chips, we mix them with the bovine bone. I do a lot of times, in this case, I use the piezo device. A lot of times I use the just the handpiece, just a round burr to create like perforations in the cortex, just to kind of invite more bleeding from the cancellous bone into the graft area, and also invite hopefully mesenchymal cells with a lot of regeneration potential. So we placed our graft, covered it in this case with 2 layers of membrane. Very important, a lot of times I make sure to secure my membranes, even if they're resorbable membranes, I still try to secure them to make sure that I have a lot of peace of mind when I'm suturing. The membrane is not moving. I have more containment of my graft and more maintenance of that space that I'm trying to augment. So we use those tacks, closure. We use nylon sutures or EPTFE sutures. And this is the X-ray. And this is 1 week later, very nice healing. Patient does have a thick biotype, so that helps, of course. Typically, what I do is I wait 3 to 4 months for this kind of guided bone regeneration. And we went back, and you can see a very nice integration of my graft. Also, the sinus area is very nicely integrated. And we place our implants without any issues with adequate bulk of bone. So the second scenario is for the same patient. That's why it says case number 1. So it's the same patient, but now let's look at tooth number 36. Tooth number 36, you can see we have the 3D X-ray. And you can appreciate in the number 3-6 position how significantly deficient this ridge is. So you have a deficiency across the entire length of the ridge, and implant placement is absolutely not feasible in this situation, of course. So if you look at the options that we have, should we do a guided bone regeneration in this case? Should we do a block graft, or can we do a split crest? If we look back at that classification that we started with, and you can appreciate that we're looking at defect of the second type, where you have deficiency in areas number 1 and 2. So it's more like kind of a knife edge. And it's not a bounded edentulous area. So you have an extended edentulous space. You have missing teeth all the way on the distal. So if you look at the options that you have, and we're looking at in deficiency in area number 1 and 2, and you have less than 4 millimeters, and in this case we have about 2, the ideal scenario would be to do a staged bone block. If you want, you can do guided bone regeneration, but I think your ability to have a predictable result, and people who have done GBR in those cases can appreciate that this is a challenging situation. So our preference was for a staged bone block. I know block grafts does not have a lot of popularity. It's not really a fan favorite. But I think there are situations where bone block is the kind of the more reasonable way to proceed. So we went with a block graft, and like I said, patient is a non-smoker, and for me that's a very important thing. I'm usually very concerned or wary when the patient is a smoker and we have to do a block graft. So I usually anticipate more complications. The ridge is narrow, less than 4 millimeters. In those cases, I prefer to do a block graft, and it's deficient across the entire length of the ridge. So it's deficient across the entire length of the ridge, and you have an extended edentulous space. So it's not only one tooth gap where you have the peaks of the prominences of the adjacent teeth that can help support a membrane if we were to do a guided bone regeneration. In this case, it's different. You have an extended edentulous space, and that's why we went with a block graft in this case. So clinically, what we did, reflection, we went to the symphysis area, we harvested the graft using the piezo device, secured the block graft. I'm not going to go into details, of course, do the technique and a lot of clinical pointers and tips that you have to make sure of. We placed a little bit of autogenous bone as well, filling those gaps. And this is the donor site, double layer closure. And then we closed the site, the recipient site with both Gore-Tex sutures as well as nylon sutures. And this is the closure of the donor site using chromic gut. This is 1 week healing. It's no issues. It's healing with the normal limits. And 6 months later, we go back, we see very nice integration of the block graft, and we were able to place regular diameter implant, a 4 millimeter implant in that site. And this is the x-ray. So again, this is another scenario where you have a deficiency and you use your assessment, you use your findings to come up with a treatment plan. Moving on to a second case, or let's say a third scenario. So in this time, the patient is also a 30-year-old Caucasian female. She has a missing tooth, non-contributory medical history. She's healthy. She smokes shisha occasionally, which is very popular in our region. And her plaque control is good. She has suffered from, several missing teeth on the maxilla and the mandible as well. But this is the site that we are looking into. This is tooth number 24 or 24, the first premolar. So patient lost that tooth. There was an attempt to place an implant that failed due to an infection and resulted in significant resorption in that site. So this is the clinical picture. And we go to our 3D reconstruction, and you can appreciate there's a significant ridge deficiency. In this case, this is a single tooth gap. And you can appreciate that we have adjacent teeth, and we have the peaks and the prominences of the bone on the adjacent teeth. So it's kind of a, let's say, a contained defect. Not entirely contained, but it's more or less because of the existing adjacent teeth. They do offer some kind of support for my biomaterials and my membrane if I do an augmentation procedure. So, and if you place your implant, you can appreciate that it's deficient across a good length of my implant. So what do I have in this case? Do I do a GBR? Do I do a block graft? Or do I do a split crest? Let's go back to how we classified this defect. Again, the patient is, for the most part, missing bone in area number 1, but also a little bit in area number 2. So it's kind of in the middle between being just a 1-4 or a 2-4. And if you look at this matrix, if you have a 1-4 situation, you can go with a GBR with simultaneous implant placement. Or if you have a 2-4, you can go with a staged GBR, but also an alternative technique is GBR simultaneously with the implant placement. So whether you consider it a 1-4 or a 2-4 position, GBR with simultaneous implant placement is an option, is the go-to option in my opinion. I'd rather not do a block graft. I have these prominences of bone on the adjacent teeth, so we went with GBR with simultaneous implant placement. And in this case, what I prefer to use is, instead of using a resorbable membrane, just because I want to bulk up that ridge, I want a space preserving device. So I want a non-resorbable membrane that can maintain the space in this area. And that's what we used. We need a space forming membrane. I use it in larger defects, and that's what we decided to do. So clinically, this is after flap reflection, and you can see I extend my incisions a little bit, again, just to make sure that I'm not too close to the augmentation area. In this case, we decided to go with the CTI membranes. These are membranes that I usually get from Neobiotech. Titanium membranes, they're very smart, very easy to use in my opinion, because they're easy to stabilize, because they have this hole and they come in different sizes, different shapes, and you can use the cover screw to actually anchor and stabilize that membrane. So you form the membrane and you stabilize it using the cover screw, and you can see the different shapes and different sizes they come in, depending on what kind of augmentation, whether you want augmentation only on the buccal or you need some augmentation also to take place on the lingual. We placed the bone graft, again, a mixture of autogenous and bovine bone, slow resorbing graft material. We extracted the number 2/6 and closure. And this is my IS2 implant, Neobiotech implant, very good primary stability. That's one of the things that I love. Although you've seen the big defect that we have, and only the apical part is really engaging the bone, but you can achieve very nice primary stability. And this is the ridge after 4 months of healing, and you can appreciate the before and after. We have very nice build-up of that ridge, and that thanks, of course, to that titanium membrane. And of course, you have to go back and remove it. Retrieving it is not hard at all. I do a small crestal incision, remove the cover screw and take out the membrane very gently, tease it off from under that flap, and you can see the nice lip of bone that we have there on the buccal. And this is a provisional that was prepared by the restorative dentist, my friend, Dr. Ayman. And this is just a week after, and I don't have the final photos, which I should get, but you can see very nice soft tissue healing around that provisional. We need to work a bit on the plaque control, but very successful augmentation in that site. So in that last scenario, we saw how we also used GBR, but we made a kind of a different decision as far as what kind of membrane we can use, and we opted for a non-resorbable membrane because of the size of the defect that we have. So the third case I want to share with you is for a colleague, a dentist colleague that I treat in Doha in Qatar. She works with me at the same center. She's a 56-year-old Asian female, and she has multiple missing teeth. Also, she's healthy, she's a non-smoker, and her plaque control is good. If you look at the panoramic x-ray, you can appreciate how we have multiple missing teeth. She's been wearing partial dentures for a very long period of time. She does have significant occlusal wear. And although, of course, the recommendation was that she goes through full mouth rehabilitation with correction of that severe wear. But honestly, she only wanted to restore, minimalistically, not to go through extensive treatment. So our plan was to place implants to restore those missing teeth. And my focus for the purpose of today's topic is on the upper right area. So the plan is to place 2 implants in the number 1-4 position and the number 1-6 position, 3 and 5 according to the ADA numbering system. You can see we have a deficient or a pneumatized sinus, so we need to do a sinus floor elevation. And in the number 5 position, which is what I'm going to focus on, you can appreciate how I have a narrow ridge. We have slightly deficient area. We need to do some augmentation there because I don't have the minimum 1.5 millimeter of bone that I need on both buccal and palatal. So if I put my implant in the prosthetically proper position, and in this case, you can appreciate we were planning on using angled abutments. Still, I have very thin bone on the buccal. So what would you do? Would you do a GBR? Would you do a block graft? Probably not. Or would you do a split crest? So let's assess this defect. So we have a deficiency pretty much in area number 1 and 2. So not only are we deficient in number 1 area, but also it's a 2-4 situation. So in a 2-4 situation, if you go back to this table, and it's an extended edentulous space because we don't have adjacent teeth on both sides, we have more than 4 millimeters. So in this case, my preference is to go for a ridge split. And I would do a ridge split mostly in the maxilla. Ridge split in the mandible is a bit more difficult and slightly carries greater risk of complications when you do a ridge split in the mandible. First, the cortical bone is more difficult to mobilize, and there's always a risk of fracture of that buccal segment that you're trying to split. So my preference, if you're going to go for ridge splitting, is to usually try and do it in the maxilla. And I know that a lot of companies recommend using a piezoelectric device where really the cuts are very thin and you sacrifice only very small thickness of bone, maybe 0.5 millimeter of bone. And they recommend, they profess that you can do it even when you have 3 millimeters of bone or even less than that. My preference is always look for at least 4 millimeters. If you have less than 4 millimeters, it becomes a bit tight because you need to maintain 1.5 millimeters on each side of the ridge. Not only that, keep in mind when you do a split crest, your implant usually moves a bit buccal. Your palatal segment is rigid, or it's put, it's not moving. The buccal segment is moving. So when you're placing your implant, automatically what's going to happen is the implant is going to tilt a bit buccally because your buccal segment is more movable. So my preference is you need at least 4 millimeters of bone, and it's better to be done in the maxilla. And in this case, that's what we did. I think we had a perfect scenario for this situation. Of course, if you're going to do a split crest, nowadays, I think it only makes sense to use it with a piezoelectric device. Doesn't make sense to use it with kind of a more traditional way. So you either need a piezoelectric device or a saw. Prefer to use it in the maxilla ridge with at least 4 millimeters. And like you saw in this area, it's like a 2-4 situation where it's deficient across almost the entire buccal segment. You have to keep in mind it's a technique sensitive procedure and there's a learning curve. So start with cases that are kind of more forgiving, simpler cases, like I said, and then you can challenge yourself more with this technique. So initially what we did the sinus floor augmentation. We let it heal, and then we came back to place the implant simultaneously in both the first premolar position and the first molar position. Let me just take a short break. Gabriel, I'm assuming you would let me know everything is okay, correct? The audio, the slides.
Yes, everything is okay. Your voice
All right,
sound very good.
perfect. I know it's a bit late during the presentation, but just wanted to double check. Okay,
All right,
so
okay.
we did the sinus floor augmentation. We let it heal. We went back because usually when you're doing a ridge split, you have to place the implant at the same time. So one might ask, why didn't you do the ridge splitting and the sinus augmentation at the same time? If I'm doing the ridge splitting, I have to place the implant at the same time. And because I cannot place the implant simultaneously in the number 6 position, the first molar position, because I only have about 2 millimeters of residual bone height, I decided to stage it. So we do the sinus floor augmentation first, wait for 6 months, and then come back and do the implant placement together with the split crest in the first molar position. So you can see the panoramic x-ray. We place the implants in the mandible already, and we have that sinus augmentation. And in the first premolar position, crestal incision, and we only reflect minimally on the buccal and palatal. You don't reflect on the buccal. I don't place releasing incisions because I want to maintain the periosteum attached on that buccal segment. That kind of works as, of course, maintains better blood supply to the buccal segment, but also it kind of secures the buccal segment better so that it does not completely get separated in case it gets fractured. So using that piezoelectric device, you place your crestal cut in the bone and you place vertical cuts. It's not enough to place a crestal cut. You need to place vertical cuts in the bone. And then gradually expand. You prepare the site. You still have to use the drills from the manufacturer. And we place the implant in both sides in the first molar position and the first premolar position. We grafted the gap with bovine bone. It did not mix it with autogenous, just use the bovine bone, covered it with a membrane and closed. And you can see this is the panoramic x-ray after the implant placement. And this is after uncovery. You can see very nice ridge width, very nice integration of the bone graft, implant very stable. And you can see how the implant is slightly tilted towards the buccal. It's not terrible, but it's slightly tilted towards the buccal. And that's to be expected when you're doing ridge splitting. And this is the permanent restoration. I don't know why the restoration on the mandible looks like that, but I think it has to do with the minimal restorative space. And the last and final scenario, last and final case I want to share with you is a kind of a more complex situation. So this is a Jordanian patient. She's a 37-year-old female. She has a non-significant medical history. She's healthy and she's a non-smoker. When I first saw her, she was referred to me with this situation. She already had an implant placed, and you can appreciate the mucogingival, soft tissue defect that she has. And she was referred to me because the restoring dentist now is stuck with this patient. The patient was sent to her from the surgeon. And obviously you can appreciate how the position of the implant is not ideal. It's not optimal, to say the least. And she was sent to me to see if maybe we can do a soft tissue graft on that implant. And this is the photo, the occlusal photo of that implant. You can see how severely buccally positioned that implant is. So it's not in a proper three-dimensional position. It's not in a proper prosthetically driven position. When you remove the healing abutment, you can appreciate the peri-implant mucosal margin. There's absolutely no keratinized tissue there. She did have 2 rounds of augmentation done there, mostly guided bone regeneration. And because of the repeated advancement of the flap, you can see now she has no keratinized tissue at all at the buccal. Luckily, when I checked on the implant was loose. This is an 8 millimeter implant, and actually it came out. So Um, you know, too bad for the patient, but honestly, I was pleased that the implant was not, that the implant came out because it's not in a proper position. Anticipating the need for augmentation in this area, and because she's lacking keratinized tissue in the area, I decided to go with free gingival graft to augment the tissues in that side. At the same time, we removed the implant, and we did the free gingival graft in the area, and it healed without any complications. And then the patient disappeared. Sorry. Then the patient disappeared for 2 years. And when she comes back, you can see how that free gingival graft now is so, very highly keratinized, like a patch situation. But at least we don't have any deficiency of keratinized tissue. We can plasty that a bit and make it look better. So now 2 years later, the patient is still wearing her partial denture, and she comes back, and now she wants to get, now she's fed up enough with the partial denture, and now she wants to get an implant to replace that missing tooth. So we take a 3D X-ray, and lo and behold, of course, not surprisingly, you can appreciate that she has a significant ridge defect. She has not only a horizontal ridge defect, but she also has a vertical ridge defect. You can appreciate it here in that red line that I drew on that X-ray. If you want to classify that defect that she has, actually, it falls in the number 2-4, kind of 3-4 situation, because we have a vertical component as well as a horizontal component. So this is more like a 3-4 situation. So if you look at your matrix and you look at your combined horizontal and vertical defect, the optimal approach is a stage GBR with a space preserving device. So it's better to use a non-resorbable membrane where you can maintain that space for augmentation. An alternative technique would be to do a bone block and a shell technique. Usually I go with those techniques if I have an extended edentulous space. If I have a bounded single tooth gap with adjacent teeth, I usually prefer to go with guided bone regeneration. And that's what we did in this case. We went with a stage GBR approach. We reflected, and you can see here on the occlusal photo, you can see the remnants of the bone grafting that was done. So I have a bulk of kind of grafting on the buccal. My main deficiency, the horizontal deficiency, actually is on the palatal if I'm going to place my implant in the prosthetically optimal position. So I have a defect that is vertical, as you can appreciate, but also has a horizontal palatal component. And that's why when we planned it, we placed a tenting screw to support my membrane. And we also used titanium membrane, CTI membrane from Neobiotech. And we actually secured it on the palatal. That's where my main deficiency is. And the membrane was secured using that tenting screw. And you can appreciate we also tacked the membrane, and we covered the buccal aspect. This is again a mixture of autogenous and bovine bone, and you can see this very generous amount of autogenous bone that we also harvested with the ACM, and we covered the buccal aspect with the membrane with a resorbable collagen membrane. So we have quite a significant augmentation. We left it for 6 months. You can appreciate the vertical improvement, let's say, of the site. And we went back 6 months later to place the implant. We retrieved the membrane. You can appreciate the augmentation that we achieved. And we went ahead and we placed our implant in the prosthetically optimal position. You can appreciate the position. And this is the periapical of the patient. And 2 months later, we uncovered the implant, not 6 months, 2 months later, we uncovered the implant, placed the healing abutment, did a crown lengthening, aesthetic crown lengthening on the adjacent teeth. And the patient had to get a 3D x-ray because she was having a resorptive issue on the lateral incisor. So we were able to visualize the position of the implant and the augmented bone, and we were pleased to see that we have plenty of bone all around that implant, but also on the palatal, like I said, because that's where the deficiency was. And this is the provisional that the patient received. She received, some plasty to kind of make the gingival margin symmetrical. This is the day of the insertion of the provisional. This is before when I first saw her, and this is after. Patient still undergoing treatment, but a significant improvement, and now she has an implant that was placed in the prosthetically optimal position. And this is before and after. At least she can lose the partial denture. So it's important to consider when you're looking at those patients and you're looking at those cases where you have a deficiency, it's very important to start evaluating the patient's medical history. Patients who are diabetic, patients who have chronic diseases, patients who have take medication, bisphosphonates, those patients are at greater risks for complications. Patients who are smokers have greater risk for complications, whether you're doing a GPR or a blood graft or whatever. So that's a very important discussion you need to have with your patient, and you have to weigh the risk-benefit ratio. Sometimes you might switch from an ideal situation for a bone block because you want to reduce the risk and maybe switch to an alternative technique where you can use GBR, which I believe offers or comes with slightly less risk of complications. So that's something you have to consider when you're making a decision. You have to consider the residual ridge width. That's a very important parameter you need to evaluate whether you want to do a guided bone regeneration technique or an alternative technique. It's very important to consider the shape of the defect and the location of the defect. So whether it's a contained defect, it's bounded by adjacent teeth, or you're dealing with an extended edentulous space, like some of the cases that I showed you. Preoperative planning is very, very important, and you need to be able to execute the technique. You have to have a good surgical approach, use the proper good choice in selecting the biomaterials, depending also on the augmentation that you want to achieve. And very, very important, you need to be comfortable with your skills, but also you need very good surgical tools. And I've showed you how, from the membranes to harvesting the autogenous bone to using the tacks, using the fixation screws, you have to be, able to select from a wide range of tools to deliver your optimal outcome. And for me, I just want to share with you how, having and using the proper tool is very important. Almost done, almost successful. But then it ends in disaster if you don't have the proper tools, and you don't use the proper tools, and you based on your experience and level of skill. Once again, this is a night shot of the beautiful city of Amman, the capital of Jordan. This is the Roman amphitheater. This is downtown Amman, beautiful place. I invite everybody, hopefully with once this corona situation is resolved and improved, all of you can visit and we can share our knowledge and experience and stories in person. Although this online experience is great because we can connect, although we are thousands of miles away. Thank you for attending. I wish that was enjoyable and there was something to benefit from. And if you have any questions, I'll be more than happy in the time available to answer them. Gabriel?
Yes. Any of question will be welcomed. Please use the Q&A session or chat communication chat button, please. If any of you have a question. So far, we don't have any question in Q&A box, so I don't think we have question waiting. So yeah, I think yeah, you can finish your lecture file. Okay.
All right. So unless we have any questions, once again, let me check.
Oh yeah, one question maybe might be from
All right,
one.
Let me stop the sharing.
Okay.
All right. All right, let me see. All right, we have one question from an anonymous attendee. So, but I don't see the question yet. So
neither me. Maybe he's writing at this moment. So let's wait. Oh yeah, there is. Here we go.
All right. So the question is, for the split bridge case, what do you think of this option? Sinus and GBR same time, then implants later on. I think it is an option, of course. But in this case, remember, the case I showed you for the first premolar position does not have an adjacent tooth. So for me, it's considered an extended edentulous space. In an extended edentulous space, when you have a deficiency in area number 1 and 2, you are trying to augment outside the envelope of the bone. When you're augmenting outside the envelope of the bone, GBR, in my opinion, you have to use a space-forming device. So it's better to use a non-resolvable membrane and make sure that you have very good stabilization of that membrane using tacking or screws or what have you. With the advantage of a split crest is that you converted a defect that is outside the bony envelope, you converted it into a defect within the envelope of bone because you moved that buccal segment, and now your defect is pretty much in the middle between the buccal and palatal segment. So that's kind of the advantage of this case. Like I said, you have to have certain conditions in those situations where split crest would work beautifully, where you have at least 4 millimeter of bone, so that you don't risk, first of all, fracture of that buccal segment, and also you have very good stability of that buccal segment. So you can do a GBR. I would go with the non-resolvable membrane, to be honest, in this case. But of course, it is an option. If you look at that matrix, it's actually one of the options as an alternative. How much bone and vertical augmentation can we grow? Usually with a GBR situation, and we have a lot of techniques for, well, not a lot of techniques, but I mean, you can use tenting screws, you can use resolvable membranes, non-resolvable membranes. But usually, I would say a safe estimate is probably 2 to 4 millimeters. I know in some literature there that says you can grow up to 6 millimeters of bone, and that's probably true in the hands of very experienced clinicians who do these type of augmentations day in and day out. What I can tell you for sure that vertical augmentation is a very challenging thing, and operator experience is very, very important. So definitely leave those augmentations, let them wait a bit until you're comfortable with your surgical skills and approach and technique and management of the flaps and handling of the defects, because they're definitely more challenging and they require more experience. How to choose the correct tenting screw height? I think it's just you need to determine how much augmentation you want to do. I think a fatal mistake is to place your tenting screw too high, which means that you're aiming for a very significant augmentation. Usually, if you notice in that last case that I showed you where we did some vertical augmentation, the tenting screw was at the level of the peaks of the bone on the adjacent teeth. I would not put it any higher than that. So that's my maximum level that I'm hoping for. The maximum usually you go with the peaks of bone on the adjacent tooth, or maybe if you're looking at the mandible, you have the curvature of the arch of the mandible, and that's the peak of bone that you use to guide you in the position of the tenting screw. Sorry, same case, but how about condensation burrs instead of split ridge? Yes, so we have a lot of options now in terms of products that you can use where you condense the bone, and instead of doing this traditional split crest, you can use these burrs that kind of push and increase the density of the bone in that area. That is an option. Honestly, I don't have a lot of experience with it, but that might be an interesting approach. What I tried to present today is nothing very, kind of more classic approach, that are more predictable, something that has been tried and tested again and again, and we know we have a lot of evidence that supports GBR and supports corticocancellous block grafting, and have very predictable results. I know that block grafting is not very popular, and it comes with greater risk, it needs more experience with these procedures. But I think there are scenarios where block grafting is the ideal way to go. GBR, if you ask me how many cases of GBR do you do versus block grafting, yes, the vast majority of augmentations we use GBR because the defects, they allow us to do GBR. So it really comes down to what kind of defect you are dealing with.
All right, thank you for the question. If you have more questions, please use our website or contact by email address, please. Thank you for the question. Okay, all right. Thank you very much for the lecture, Dr. Murad. It was very awesome. So it was very good. Good job, thank you. And we would like to have your opinion for today's webinar. There will be an extra pop-up screen with 5 questions. So please share 1 minute for us. We're gonna always try the best to improve the quality of webinar for your satisfaction. And please stay connected with Neobiotech social media to communicate with us more. Search Neobiotech in Facebook and YouTube, and do like and subscribe to get more information. The lecture will be uploaded in our website with the YouTube video, so you can watch again this lecture later at any time. For the next upcoming webinar, it will be a 5th August next Wednesday. Dr. Christopher from Australia will give the lecture. The title will be Aesthetics in Implant Dentistry, Strategic Factors for Success in English. Please remind that we do not have a translation service. If you have any questions or information needed, please contact us by email address. And don't forget, you can get more information in our website and social network service. Thank you for attending our webinar today. We hope all of you enjoyed this time. Please have a good day or good night. See all of you again sooner. Thank you and bye.